Welcome back, everyone. I am your lead instructor, Harshal. We just wrapped up an intense look at MDC 19, covering mental diseases and disorders, and now we're jumping right into part 114 of our IPDRG masterclass. Today, we are taking a deep dive into Major Diagnostic Category 20, which covers alcohol and drug use, as well as substance-induced organic mental disorders. Before we get into the thick of it, if you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. We've got a great lineup today. We'll start with MSDRG architecture, move into POA rules, talk about defending your revenue with CDI, break down substance abuse coding, and wrap it all up with a real-world case study. Let's get right to it. Section 1. Demystifying MSDRG architecture. To accurately code incredibly complex cases like inpatient chemical dependency or acute withdrawal, you absolutely must master the overarching architecture that dictates how these facilities get paid. The bedrock of accurate coding is knowing the difference between the primary reason for admission, why the patient stumbled through the ER doors, like severe agitation, versus the definitive principal diagnosis. The principal diagnosis is the condition established after study that is chiefly responsible for occasioning the admission. This is huge because it dictates the entire major diagnostic category. If a patient comes in hallucinating, but after study it's definitively diagnosed as alcohol withdrawal delirium, which you probably know as delirium tremens, that final diagnosis is what drives our DRG assignment. Once that principal diagnosis assigns the MDC, which is MDC 20 for our focus today, the grouper gets to work. It partitions cases into medical versus surgical based on whether a significant operating room procedure was performed. For substance abuse, we are almost exclusively living in the medical partition. But here's what makes MDC 20 completely unique. It uses a structural grouping logic that actually splits cases based on the treatment modality. It differentiates between detoxification only, rehabilitation therapy only, and a combined stay of detox and rehab. This grouping logic directly builds into the DRG triplet structure for MSDRGs 895 through 897, which handle interventions for alcohol or drug abuse. Capturing a major complication or comorbidity, an MCC, like severe alcohol-induced encephalopathy or a substance-induced psychotic disorder, is a total game changer. It drastically increases the relative weight in the hospital's reimbursement. A standard CC bumps you to a middle payment tier, while cases lacking either of those drop to the lowest tier. Precision here is literally everything. Moving on to Section 2, our financial guardians, the POA rules. So what happens if that high-paying MCC wasn't actually present the moment the patient arrived? That brings us to present on admission, or POA indicators. These flags are the true financial guardians of a claim. They tell the exact story of the patient's condition at the precise moment the inpatient admission order is written. If a condition is marked N, for not present on admission, CMS slaps a hospital-acquired condition label on it. The financial fallout from that N flag is massive. Think about it. If a patient is admitted and subsequently develops a severe complication that qualifies as an MCC, but it's flagged N, it is completely tossed out of the DRG calculation. It cannot be used to boost the payment tier. CMS will pay at the lower rate, and the hospital might even get hit with quality review penalties. It's a stark reminder that quality of documentation directly equals quality of revenue. So how do we protect that revenue? Section 3, defending with CDI. We rely heavily on clinical documentation integrity, or CDI, to fight off revenue losses from vague notes, and more importantly, to defend against commercial auditors who constantly try to downgrade an inpatient stay to a simple ambulatory detox. We have to be on the lookout for query triggers like ambiguous diagnoses or missing POA status. In MDC 20, you have to formulate incredibly precise, non-leading queries to clarify if a patient simply has substance use, abuse, or actual dependence, because the ICD-10-CM hierarchy rules treat those very differently. You also need airtight queries to clinically validate that a patient truly requires an inpatient medical detoxification level of care versus just outpatient observation. Let's put this into practice. Section 4. Substance abuse treatment coding. Let's apply this MSDRG logic straight to our specialty deep dive for MDC 20. This category deals with a really complex clinical landscape: acute medical stabilization, severe conditions like Wernicke-Korsakoff syndrome, and inpatient rehab. But here's an absolutely critical diagnostic sequencing rule. You have to know the difference between an adverse effect and a poisoning. MDC 20 is strictly for substance dependence and withdrawal. If a patient presents with an acute overdose, the principal diagnosis shifts over to MDC 21 for poisonings. And remember this golden rule: illegal drugs like cocaine, heroin, or unprescribed opioids always default to poisoning.
Here's a perfect scenario illustrating this sequencing mandate. If a patient presents with cocaine-induced chest pain, the principal diagnosis must be sequenced as the cocaine poisoning first, followed by the chest pain as a secondary diagnosis. Properly distinguishing between these overdose scenarios versus uncomplicated acute withdrawal is one of the biggest targets for payer audits, so we have to get it right.
Now, for patients admitted strictly under MDC 20 for dependence, detoxification is a common treatment. But listen closely. Inpatient detox isn't just letting someone sleep it off. To clinically validate this level of care, auditors are hunting for expert validation, like ASOM criteria level 3.7 or 4.0 documenting severe withdrawal risk. They expect to see hard data from clinical titration scales. We're talking a CIWAR score of 15 or higher for alcohol or elevated COW scores for opiates. The documentation absolutely must show active IV hydration, tapering protocols using benzodiazepines or phenobarbital, continuous vital sign monitoring, and seizure prophylaxis. When it comes to capturing the actual procedures for these intensive stays, we jump over to the ICD-10 PCS Substance Abuse Treatment section. It's actually a very uniform, predictable structure. It always starts with the letter H for the section. The second character, body systems, is universally Z for none. And characters 5, 6, and 7 are also just Z placeholders. Character 3 is where the magic happens. That's the root type. And it allows us to perfectly distinguish between physical detoxification, which is root type 2, and psychological treatments. Individual counseling is 3, group counseling is 4, and medication management, like keeping a patient stabilized on methadone, is root type 8. Nailing the correct root type is what ensures the MSDRG accurately flags the case as detox only, rehab only, or a combined stay. And hey, keep a very close eye on the discharge disposition. This is incredibly specific to MDC 20. If a patient admitted for primary substance dependence leaves against medical advice, or AMA, it triggers a totally unique DRG assignment. MSDRG 894 is triggered the moment a patient with alcohol or drug abuse leaves AMA prior to treatment completion. Think about that. The discharge disposition literally overrides and alters the MSDRG grouping logic. All right, let's bring it all together. Section 5, Case Study and Conclusion. Let's lock in everything we just covered by running through a real-world scenario. Imagine you're auditing a chart for a patient in a structured inpatient chemical dependency rehab program. The clinical note specifies that the patient received interpersonal-based individual counseling. What is the exact 7-character ICD-10 PCS code for this specific therapy? We just build it out systematically, one step at a time. Step 1, Section H for substance abuse treatment. Step 2, System Z, because we don't have a specific body system. Step 3, root operation is 3, designating individual counseling, and Step 4, the type qualifier is 4, which specifies the counseling was interpersonal-based. Finally, we just tack on our 3 placeholder Zs at the end, giving us our flawless compliant code, HZ34ZZZ. By capturing this with such precision, you guarantee the case drops into the correct rehabilitation-specific MSDRG, ensuring the hospital gets properly reimbursed for that multidisciplinary addiction therapy. And that wraps up our deep dive into MDC 20 and the incredibly nuanced coding mechanics of substance abuse and detoxification. But don't go anywhere, because next time in Part 115, we are taking on MDC 21, diving straight into traumatic injuries, overdoses, and the toxic effects of drugs. Before you click away, I want you to ask yourself, is your facility bleeding thousands of dollars simply because a single POA flag or an AMA discharge wasn't queried properly? Quality documentation isn't just about compliance. It is your ultimate financial guardian. If you're enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.